Hi, I am back. We're going to go through the second round of neuroimaging. We're going to go through hypodensities and then MRI, and I think we'll call it good there because that's enough. And it gets a little dry, especially with just me talking. And again, as I've said, we're going to be able to go through some neuroimaging when we meet together on Thursday afternoons. So I am hoping you guys can see these slides, but this is where we left off after the last talk. We talked about hyperdensities. You remember CT measures density, hyperdensities, and hypodensities. These are some hypodensities. So I think we mentioned before about how you have a patient who has had surgery or some kind of instrumentation. They can afterward have pneumocephalus. And air is very hypodense, you can see. And you can get pneumocephalus for other reasons as well. Trauma is a popular reason at Harborview. This here, as it says below, is a hypodense infarct. So infarct is the term that we use to refer to the damage due to an ischemic stroke. And here, this patient has had an ACA and an MCA territory infarct. We'll talk more about CTs and acute ischemic stroke later, but you probably already know that acute ischemic stroke doesn't show up on the initial CT. Sometimes there are some subtle kind of findings, but you typically have to wait a while for a stroke to show up on a CT. And then over here we've got a mass. This is a mass. This is a post-contrast scan. These are all CTs, of course. This is a post-contrast scan showing you this ring-enhancing lesion, and then this surrounding hypodensity, which is edema. I think we pointed that out around some of the hemorrhages we saw before. Okay, so CT for ischemic stroke, again, typically early on the CT is negative, although there may be some very subtle findings. It takes hours for ischemic changes to show up on a CT, and sometimes, quite honestly, infarcts are so small or they're buried in the posterior fossa that really a CT doesn't pick them up very well, and an MRI is a lot more revealing. We do, that being said, CT is still our imaging of choice if somebody is having an acute ischemic stroke. And we'll talk more about stroke later, but you come to this decision point when you have a patient come in who has suddenly had something neurologic happen and you're really thinking it could be a stroke. You're not sure if it's an ischemic stroke or if it could be a hemorrhagic stroke. You got to get the CT. CT is fast. It's great for blood, right? If you see no signs of blood and you see nothing concerning yet, you can consider pushing TPA or doing something else to manage that stroke. And we'll talk more about that later. All right, so early signs of ischemia on CT. If you look carefully, you can start to see some of these. And these are some of the same sorts of changes that we were looking for before in the patients who had bleeds. So some of the things we can see are blurring of the gray-white junction. It's a little hard to see here. But if you can kind of imagine that you can see some gray-white differentiation over here on the right side, on the left, you don't see it. It's just all the same density. It's all the same. And then effacement of the sulci, we've talked about that a lot before, and you can see on the right side here, nice sulci, the insula, and over here, it's all kind of effaced. And then over time, this is the infarct, and then this is a re-scan of the infarct sometime later. And you can see that the infarct starts to become hypodense. And so initially, you get these subtle kinds of changes. As time goes on, hours and so forth, you can start to get this hypodensity. Okay. There are a couple of cases we're going to go through just to kind of highlight some of this. Don't get too hung up on the cases, but this is Mr. H. When you see this here, this reminds us this is this gentleman. As we go through his imaging, he's a 65-year-old man who has a history of cancer and was on a cruise, actually on up in Alaska, when he developed headache, left-sided weakness, and then also had some cough and congestion. He was febrile in the emergency room. So what is our workup? What are we going to do? He's in the emergency room. He's had this headache, left-sided weakness, cough, congestion, this cancer history. We're going to get a CT, right? And we probably would think about getting that CT with contrast. We haven't talked about contrast much yet, but anytime that you are worried about malignancy, inflammation, infection, those are times to really think about giving contrast. And in his case, we're worried about that. We're worried about two things, right? He's febrile, so we're worried he could have something like an abscess up in his head. And he's also got this really rich history of cancer, which makes us worry he could have a MET. Now, as a side note, you may know that melanoma goes to the brain, and when it does, it's prone to bleeding. Prostate cancer doesn't tend to go to the brain. Very rare for it to go to the brain, but it does go to the spinal cord, and it can impact, or it goes to the spine, and it can impact the spinal cord that way. Just as another aside, the four kinds of tumors you should know about that metastasize to the brain: lung is by far the most common, breast, melanoma, as we talked about, which is prone to hemorrhage, and then renal cell carcinoma, which also can be prone to hemorrhage. Okay, so this guy comes into the ER and we get a scan on him. CT, you know this is a CT, right? Because the big bright skull there, we talked about how the falx can sometimes calcify. You can see a little nub of that there. And what's going on here? These are all from the same study. They're different cuts. And by now, you can see some of the things that are going on, right? So there's something in the right hemisphere. It's a hypodensity, right? It's kind of all a big blur there, but there's definitely hypodensity relative to the right. And then it kind of looks like there's maybe this well-defined kind of hypodensity with more surrounding hypodensity. So perhaps a tumor or maybe an abscess, who knows, and then some surrounding edema. Sometimes it's hard to tell if something is hyperdense around here. So this little part here and these little parts might look hyperdense, and you might wonder if they're blood or something. But sometimes it's just the normal brain tissue appears extra bright. Okay, so that was the gentleman with the brain tumor. This is another woman. This is Wenatchee. It's a beautiful picture of Wenatchee. Mrs. O, she is a 65-year-old Spanish-speaking woman. She's got hypertension. She gets an acute headache, and she's taken to her local ED where her blood pressure is sky high. So what is our test going to be? We're going to get a CT on her. We're getting a CT. Why are we getting a CT? It's fast, and we're worried that she's had a bleed, right? Because she's hypertensive, and she's got a headache. Just as another aside, ischemic stroke, headache doesn't tend to be a very common symptom, but it definitely is with intracerebral hemorrhage, intracranial hemorrhage. So we're going to get a CT on her. Here's her CT. And these are different cuts. So axial, sagittal, coronal. Remember, we're trying to use those. This is just an illustration to remind you a little bit about the anatomy of the ventricles, the lateral ventricles, the fourth ventricle, and so forth, the aqueduct. And then over here, you guys can tell what's going on here, right? You can definitely tell because we've gone through this and you remember this. So she's got blood in her ventricles. You can see some blood in the right lateral ventricle, posterior horn, as well as up here. And you see it all tracking all the way down. So she has a hemorrhage, as it turns out, in her right basal ganglia that ruptured into the ventricle. Remember when we talked before about intraparenchymal hemorrhages, when they're deep, like in the thalamus, the basal ganglia, they tend to be more likely due to hypertension, and that certainly fits her history. And so you've got these patients to kind of keep track of, okay? So you've got her, and then we've got this guy to keep track of from Poland. He is a 57-year-old man who is living in Seattle, not a big goer-tour of doctors. He's a smoker. He has a blood pressure cuff at home and does take his blood pressure, and it's been pretty high. He was found slumped in a chair, unable to speak by his roommate, and blood pressure was sky high in the emergency department. He comes into the emergency room. What are we going to get on him? A CT, right? CT fast. He's probably pretty unstable, definitely with this blood pressure. We don't want to lose sight of him for very long, so we'll probably put him on something to bring his blood pressure down, get him in that scanner, and see what we see. And of course, we're worried about blood with him as well because he's hypertensive. He's a smoker, and he's got this sky-high blood pressure. Of course, an ischemic stroke can be a consideration too. So these are all him, same study, different cuts. And let's see if we can see something kind of subtle. So this is really tough, right? But I would like to have you kind of look very carefully at the left hemisphere. So if we look over here, right? You can see sulci over here, not so much. And you can kind of imagine that the gray-white differentiation is a little bit blurred. Maybe a little bit here, the insula is a little crisper over here than over here. It's hard to tell there, kind of hard to tell there, but this one kind of makes you wonder if there isn't kind of an evolving hypodensity. And then this one I think is pretty more obvious than the other ones. Again, subtle findings, but these are the things that you're going to be looking for. And so in the right hemisphere, again, sulci over here effaced. And so this gentleman has an evolving left MCA stroke, left MCA infarct. So he gets his scan repeated a few hours later. So typically what we do if somebody comes in with this kind of a deal and we think they're having a stroke and we can kind of see it on the CT, or we presume that it's there because of the symptoms, we treat for stroke. We don't wait to see it on a scan, right? You treat for the stroke. And so he would get admitted. He would get his blood pressure brought under control, roughly under control, as we'll talk about later when we talk about stroke. We tend to do permissive hypertension in the acute treatment of stroke, so we let blood pressures run a little bit high, and we'll talk about that later, why we do that. So several hours later, he's in the hospital, and we get another scan on him. And this is it, and I think you guys can appreciate that there's something definitely going on in the left hemisphere. Not only do we not see those sulci and that gray-white differentiation, but it's an evolving hypodensity, an evolving infarct. You might wonder, well, why doesn't he have mass effect? Why aren't these ventricles pushed over? And it's possible that as time goes on, he's going to start to develop more and more edema. And in fact, the peak edema after an ischemic stroke is like 3 to 5 days after the stroke. And so he may develop such edema in the coming days that he does have some midline shift there. And you may know that sometimes people, if they have a very large infarct, large MCA infarct or large MCA ACA infarct, and they've got a full brain, because they're young, they have a healthy brain, they really can get into trouble because, again, you have this hard cranial vault, and if you have swelling going on around an infarct, you could get into really big trouble, right? And so sometimes these patients have to have the skull taken off, a piece of the skull taken off, a craniectomy, and that piece of skull saved in the freezer until later time, and then put back on. Okay, MRI. MRI, so CT. Let's think about CT one more time. CT, it uses radiation. It assesses hypodensity, or it assesses density, so hypodensity, hyperdensity are the kinds of things we talk about. I didn't mention this before too much, but you can give contrast with CTs, and it's iodinated contrast. You probably know that there's some issues with iodinated contrast. One is that it's potentially nephrotoxic, so we try to avoid giving it to people with fragile kidneys. And then the other thing is that there are some degree of allergy associated, that people have allergies associated with iodinated contrast, and sometimes they need to be pre-treated for their allergies. Okay, so now we turn to MRI, which is a different modality, doesn't use radiation, uses magnetism, and it measures intensity. So instead of density, get used to talking about intensity here. So it's pretty easy if you make that switch, density to intensity. You can just talk about hyperintensities and hypointensities, and that relative to the surrounding brain tissue. MRI, you probably know, takes a while to acquire the images. You're in this little tube, and it can take, for a brain MRI, it can take at least 30, 40 minutes, and if you're giving contrast, it can take up to an hour. Some studies, if you're doing the brain and the spine, patient could be in there for quite a while. So it's not a study that you're going to do on somebody who's unstable, somebody who is panicking, somebody who is really claustrophobic. You're going to need some planning there. You already know, too, that it's not safe if somebody has metal in their body, and you're going to encounter so many patients. You probably already have patients that have metal in their body somewhere. Metal we don't even think about, right? So sure, we know about pacemakers and things like deep brain stimulators and all of that, implants, but it turns out that there are other things, too, like shrapnel that we don't necessarily think about, and certain tattoos. And so, if you're not sure, just talk to your MRI technician. All right. So advantages, more sensitive, right? So I still maintain what I said before, that for acute blood, CT is the best, but for most other things, MRI just gives you so much more information. And it really helps, as you'll see. It's the gold standard for when you're evaluating something like a brain tumor or an infection or multiple sclerosis. And that's certainly true in the spine as well. We aren't going to talk much about spine imaging, but CT of the spine gives you a good look at the bones. But if you want to see the cord itself and see more resolution of everything, you get an MRI of the spine. So we've already talked about those points. Here's where it gets confusing, right? This is why MRI blows us all away, is because MRI is really, there's so many sequences, and they have all these confusing acronyms and stuff. So we'll go through some of these, but this is again a reminder that to communicate with your radiologist or your whoever is protocoling the study for you, because they will get you certain cuts and certain sequences if you tell them what you're worried about. I should say too, sometimes this confuses people, and I didn't quite understand this until I was well into residency, but when you order an MRI, you order it, patient goes and does it, and then they do a lot of formatting of these things, and so you get all these different sequences from that one study, and then you can also get different views, so axial, sagittal, coronal, and which ones are done depends on the clinical question. Okay, we'll talk about these guys really quickly, and I refer you to the textbooks, the text chapters that I mentioned in the study guide. Those are really helpful and go into a lot more detail on the physics, which I'm definitely not going to go into. Okay, T1 is a lot. T1 is anatomical, and so gray matter is darker, white matter is brighter, so it's anatomical. T2 is kind of the opposite in that respect, so the gray matter up here, the cortex, is bright, and then the white matter is darker. It's a really good sequence for looking at pathology, especially in the brainstem. So if you're looking to see that there's something in the pons or whatnot, this is a great sequence to look at. And then FLAIR is when you're going to see a lot, and FLAIR is a great all-purpose sequence to look at if you want to get the lay of the land. So FLAIR is just like T2, so you can see the gray matter is brighter than the dark matter. But notice that the CSF is blacked out. It's nulled in a FLAIR. And so that allows you to see all these things around the ventricles. And as you'll see as we go through some of the diseases, there's a lot of stuff that happens around the ventricles. So this is a useful sequence and a really useful study. Okay, so then we've got three sequences down. We're going to go through these two. These two, think of these as kind of our stroke sequences, acute ischemic stroke sequences. So they go together. So DWI, diffusion weighted imaging, and ADC, apparent diffusion coefficient. Basically, if you see something that is a lesion that is bright on the DWI and dark on the ADC, so you look at the two sequences side by side if you can, we call that diffusion restriction. And that's an indicator that the sodium-potassium pumps in the cells are dead and that water is infusing into the cell. So here's an example. So the images can be pretty grainy. These are extra grainy, but as you'll see when you look at diffusion in ADC, the images are not quite as crisp as some of the other images. But here we have some lesion that's bright on the DWI, dark on the ADC, bright on the DWI here, and dark on the ADC. So these are all examples of what an acute infarct would look like on MRI. Now, acute ischemic stroke is by far the most common thing you're going to see that diffusion restricts, but some tumors will, and importantly, abscesses can. And so sometimes, in neurosurgery, when we're concerned that there could be an abscess, an MRI can be a helpful study, including these sequences, DWI and ADC, to see if there's diffusion restriction. Wow, this is not as bad as it seems, huh? There's now these two sequences. You're almost done. So GRE, gradient echo, and SWI, susceptibility weighted imaging, and these are relatively new sequences that have really been very helpful and very informative because they show blood, old and new. And so if a patient has ever had a bleed in their head, it's going to show up on this sequence, these sequences. And so GRE is the older sequence. SWI is newer and is a lot more sensitive. And so you may see both or either. But with GRE, so here's an axial GRE, and you can see there's this hypointensity, right? Hypointensity, and maybe the hint of some other hypointensities there, hard to say, and that indicates old blood. And you can also sometimes on these, well, not sometimes, but you can also see on these that the blood vessels will be dark too, which makes sense because there's blood in the blood vessels. Over here, this is an example of microbleeds. So sometimes patients can have these little microbleeds that don't show up on a CT, but they've occurred, and they're an indicator that this patient could be at risk for having a very big bleed or more bleeds. And so this is a very helpful sequence for us in stroke management. We talked last time, just as a little aside, we talked last time about how with intraparenchymal hemorrhages, when they are in the lobar area, out in the lobes, we wonder about something like cerebral amyloid angiopathy, especially if it's an elderly patient. Sometimes these sequences can help us tell if the patient has cerebral amyloid angiopathy, and this is a probable case of cerebral amyloid angiopathy where you can see the temporal lobes especially are just kind of littered with these little microhemorrhages. Okay, so we're going to go through MRI back to these three patients. This is the gentleman that had something in his right hemisphere. You remember this. So here's his MRI, and MRI, again, it can be easy to mistake one type of study for another. It gets kind of confusing. You're looking at all these things in a dark room. This is MRI, right? We don't have that bright, thick skull, so that can help you there. And look at the orbits. Look at all this detail we can see on the orbits. So that's a good way to know that you're looking at an MRI. And so here, what do we have? Well, this was what we were worried about over here. So this looks like this is a T1, right? Because gray matter is gray, white matter is white, the CSF is dark. There is not contrast, and I'll show you how we know there's not contrast. But we have this hypointensity, so it was hypodense, now it's a hypointensity on MRI, and surrounding hypointensity as well. So that's what it would look like on MRI, and you can see on this particular cut that there is a little bit of mass effect in that this ventricle is getting pushed over a bit, especially here, huh? In there. All right, so now this sequence here, this is T2. How do we know it's T2? Well, the gray matter is brighter than the dark, or the gray matter is bright, the white matter is dark, and the CSF is bright. So this is a T2, again, without contrast, and I'll show you how we know it's not contrast. And notice how you can see a little bit more detail here of that lesion, a little bit more, huh? And we can kind of make out some of the gyri and stuff in there. So it looks a little bit more, it's a little bit more detailed, but it still doesn't quite tell us what we need to know. Except we can kind of make out that there definitely is this really rather uniform mass and surrounding edema. So then this, of course, would be flare. And you can tell that because the gray matter and white matter, and then the CSF is dark. And these are the same cut, as you notice, and so it's not like we're going to see a whole lot new. But flare really does make the edema pop. And so all of this is edema. All of that is edema, vasogenic edema. And so that really pops out when you have flare. Okay, so then he also gets DWI and ADC sequences. You might wonder, why would you bother doing that? It makes sense, though, to do it because we already just talked about how with abscesses you can have diffusion restriction, and this gentleman was febrile, pretty febrile, so a brain abscess would have been on our differential diagnosis, especially because brain abscesses can get a lot of edema around them. So does he have restricted diffusion? Dark on the DWI, bright on the ADC. No diffusion restriction. So this is not a stroke, not an abscess. So these are sagittal images, as you know, and you can really see all of that edema. And a coronal view, again. I haven't shown you contrast. I think we look at a few more cases and then we'll come back and look at contrast. So remember this gal from Wenatchee? She was the woman with a bad hypertension and the headache, and we determined that she had a right basal ganglia hemorrhage. Well, she got an MRI too. So why would you do an MRI on somebody with a bleed like that? There's different reasons, and you maybe could argue that it's not really necessary. In her case, it was because she came to Harborview, where we are in the habit of getting MRIs when we can on patients with bleeds, just because it gives us information. For example, if there are microbleeds and so forth, or old infarcts, it helps us know how to manage for secondary stroke prevention. So here is her T1, her T2, and her flare. We talked about how there's a lot of stuff you can see around the ventricles. Here's some stuff you can see around the ventricles. So microvascular disease is one of the things that shows up around the ventricles. And this woman with her chronic hypertension does have some microvascular changes there. And then, GRE. So I told you about the gradient echo and the SWI. She had a GRE, which just shows this hemorrhage here. So that's not very exciting. And all in all, fortunately, her MRI is not that exciting. Why did I put this here? Well, you remember, she had a lot of blood in her ventricles, and so she is at risk for hydrocephalus, and she did indeed require this procedure. This is a ventriculostomy, can be done at the bedside, but basically this is how the surgeons insert a drain into the ventricles to manage hydrocephalus. This gentleman, remember the gentleman from Poland? So he gets his MRI later after all his acute stroke management is figured out. And here is his flare. And you can see how different this hemisphere looks from that hemisphere, right? So it's all kind of swollen. It's all kind of effaced. It doesn't look very pretty compared to over here. Diffusion restriction. So DWI, bright, ADC, dark. Acute ischemic stroke, diffusion restriction. His ACA territory is spared, so that's good. But his MCA, he pretty much got his whole MCA territory, which is no good. Contrast. MRI, of course, can be done with contrast too. It's not iodinated contrast, it is gadolinium. And gadolinium, you may know, is contraindicated for patients with renal failure, not because of its effect on the kidneys, but because it can increase the risk of this nephrogenic systemic fibrosis. So sometimes that can be an issue you have to deal with if you're ordering a contrast MRI. And again, remember, tumor, infection, demyelinating disease, things like that are the times you're going to really want to make sure you give contrast. Okay, this is just this is a small point, but it's a good point to remember. So sometimes we get fast and loose with the word enhancement. To me, what enhancing means is that a lesion takes up contrast, indicating that there's a breakdown of the blood-brain barrier. So if you want to say that a lesion enhances on MRI, you have to really look at the T1 pre-contrast and then the T1 post-contrast. So here we got a T1 pre, T1 post. This is a coronal view, right? And it's not hyperintense on the pre-contrast, but it is on the post-contrast. So we can say this is an enhancing lesion. These are contrast studies. Not sure what my point was here, but other than that, you can tell it's a contrast study because the blood vessels light up, the nose lights up. And so much like when you're looking at, I guess because this is CT, but then down here I'm making the comparison that you can also see the blood vessels light up on MRI. So sorry, it's kind of a bad slide. So our gentleman, the guy that was on the cruise ship, as part of his MRI, he of course gets contrast T1, no, T2, sorry, T1 pre-contrast, this should say T1 post-contrast. T1 post-contrast, yes, he's got a ring-enhancing lesion, and then all this surrounding edema. I hope I didn't confuse you. He got gadolinium. Before the gadolinium was pushed, he did not have hyperintensity around this mass. After he got the gadolinium, he has hyperintensity around here. There's breakdown of the blood-brain barrier. And you know what we're going to do? We're going to talk about vessel imaging, and we're going to call it good. We're not going to go over spine or cases. Okay, so vessel imaging. This is important for stroke, for aneurysm, AVM, lots of things you guys are seeing, even in the spine. And so you can get vessel imaging with a CT or with MRI. CT angiogram, MR angiogram is what we call those, sometimes abbreviated CTA, MRA. So you can look at the vessels of the neck, vessels of the head, so the carotids, the vertebrals, or the vessels in the head. For acute ischemic stroke, you want both, right? You want the vessels of the head and vessels of the neck if you're working up acute ischemic stroke. If you're working up a suspicious head bleed, you need a CTA of the head or an MRA of the head, and that will help you identify if there's an AVM, an aneurysm, whatnot. Okay, CTA, that's probably the study we get the most, especially in a stroke setting, because we've already got the patient in the CT scanner, and it's very quick and you can get very good images. You use the iodinated contrast, as we discussed before. You can also get vessel imaging, of course, with an MRA. The quality is pretty good. I don't know that it's a whole lot better than CTA, although there are different kinds of work sequences that are being done to look at the characteristics of the vessel wall and so forth. But you can get very good images with either of those. And as we discussed before, the gold standard for study is a catheter angiogram. If you don't, for some reason, you don't have access to CT or MRI, you can look at the vessels with a carotid duplex. You don't really get good imaging of the posterior vessels, right, the verts, but the carotids, you can get some indication of the carotids, and that can be very helpful. And then you can insonate the intracranial vessels with a TCD or transcranial Doppler. Again, not maybe as useful as a CT, but it's a study you can do. And if you're at Harborview, you know that we'll get both sometimes, because you can get a little bit of different information from both. Okay, so CTA head here, MRA head. I should have mentioned with an MRA head, you actually don't have to give contrast. So you can do that without gadolinium, and you can get beautiful images like this. If you're getting an MRA of the neck, you do need to give contrast if you want to have a good image because of the movement artifact from the chest. But you can see, beautiful images here. You probably already know this from looking at scans, but you don't really get all the vessels in one cut. So when you're looking at the circle of Willis, you kind of have to scan up and down to see everything. But here you've got the carotids coming up, the MCA, ACAs, the PCA coming around here. So our gal, she got some vessel imaging. She was the gal from Wenatchee, and it was not very exciting. But this is a CTA. And fortunately, it didn't look very exciting. You can see, the vessels of the neck, vessels of the head. You can see the vertebral arteries back here. They're vertebral arteries because they go through the vertebrae. And then you can see the carotids coming up. And carotids, when we talk about, this is a CTA, right? When we talk about hyperdensities, calcification can be an issue, especially common at the carotid bifurcations. This gentleman, so he was the gentleman from Poland, and he got vessel imaging. So you can see he's got this is a coronal view, and coronal view is a nice view to look at the vessels coming up, and back here to see the basilar artery come up and bifurcate. And what happens is that he has a cutoff. So cutoff meaning that the left MCA, M1, which is the first branch of the MCA, comes out and ends in clot. You can't tell from this image because you can't scan up and down and see if it's on, if it's just off the plane, but there's nothing. So he has an acute ischemic stroke from a left MCA thrombus. And you actually could kind of see that here because you see these nice vessels out here in the distal MCA and not here. So this gentleman did have a mechanical thrombectomy. We're going to talk about this more when we talk about stroke, but you probably know this is the standard of care. If somebody has a large artery ischemic stroke with clot, is to take them down to the cath lab and dig that clot out. And so here's the clot. So they took him down to angio, and they put dye in the MCA, and it just ended in clot. They went in and they did some clot retrieval, and they were able to recanalize a little bit, restore a little bit of blood flow, but not nearly enough. Okay, so we're not going to talk about spine or cases. We can talk about those things later if you like, but again, I just wanted to kind of give you a little bit of a little bit more information to help as you're learning about imaging. And if you have any questions, let me know. Again, we will be going over this when we meet on Thursday, so I'm hoping that you guys will feel comfortable just kind of saying what you see as we look at scans, even if you're wrong. I'm wrong all the time. All right, I will see you guys later. Bye.